This is one talk which I delivered during one of the CMEs meant for postgraduate ophthalmology students at Rama Medical College on 12th of September 2023. So this is about clinical pearls in management of diabetic retinopathy targeted for postgraduate students. Now, why is it important for all the postgraduate students to learn this specialty? Because as per this publication regarding prevalence of diabetic retinopathy in India, it says that up to 18% of newly diagnosed diabetes patients already have diabetes retinopathy, and this translates into more than 10 crore diabetic retinopathy patients, and unfortunately this affects a population which is 40 to 60 years of age, which is the most productive years of the age. So this is an important concern, and we have a significant burden of these patients. Now, when you have a big health problem, there has to be a strategy to deal with, and the postgraduate students have to be sensitized to this, because each one of us may not select a retina as a subspecialty for practice, but still they can contribute, and thus the participation of all tiers of medical establishment in fighting diabetic retinopathy is an important concern. Now, how this can be executed is that we can divide the management of diabetic retinopathy in these compartments. So one is screening, then we have the diagnosis and the classification of the stage of the disease, and then the medical management, which is relatively easy to deliver, which is less of investment and less of skill required. And then we have the surgical management, which is for advanced cases and requires more investment and more skill acquisition. So in a nutshell, we should have a screening system which incorporates a large base of ophthalmologists who can screen and then diagnose, and then as we progress towards the management plan, the pyramid shrinks and we have less people required to do this, and this way the burden is distributed and it is possible to manage them. Now what I mean by screening is that the baseline fundus evaluation at the time of diagnosis is such an important issue, because as we have just seen that more than 18% of diabetics newly diagnosed may already have retinopathy. So you have to establish a baseline, and if this is normal, then yearly follow up, and if it has some stage of retinopathy, then depending on that stage we can plan the visits of the patient. And this screening can be done by OPD tools like indirect ophthalmoscope, direct ophthalmoscope, and 90-degree examination on a slit lamp. If we want to improve upon this screening process, then we can have a fundus camera which can document the fundus findings in form of a photograph, which can be shared, which can be used in patient education, and it will be valuable for follow-up visits to gauge the progression of diabetic retinopathy. Now these fundus camera now Indian makes are available, which are very cost effective and they can be afforded by all of us. Then comes the second stage, that is the diagnosis and classification of the disease. So for this, a standard ETDRS classification is prevalent, which divides the retinopathy into PDR, NPDR, and NPDR has mild, moderate, severe, which simply is a continuous spectrum of disease which translates into a PDR or proliferative retinopathy with high risk PDR and advanced PDR involving tractional detachments. So this can be a strategy which can be practiced by nearly all of our postgraduate students. And in addition to this classification, we have few more features like hard exudates, which are added nuisance, because once you have hard exudate at the fovea and macula, the vision is permanently compromised. We can have macular edema. This is something which is easy to treat and with very good outcomes. And then we have the traction detachments, which are very complicated and difficult to treat. So this is in a nutshell about the classification and staging of the disease. Once we go to management plan, then we can see that diabetes is a systemic problem, and not only that elevated glycemic or the blood sugar levels are detrimental, but by the time when the retinopathy develops, the patient is already suffering from various other problems like renal dysfunction, anemia, hypertension, and deranged lipid profile, and they all contribute to the worsening of the diabetic retinopathy. And the converse is also true, that if you improve upon the systemic comorbidities, the diabetic retinopathy will also improve. So metabolic control of blood sugar is must, and apart from that one should look for renal functions, anemia and hypertension control and deranged lipid profile. Apart from that, personal habits like smoking and tobacco use should be discouraged. Apart from that, the medications which can be used specifically for retinopathy are topical steroids and NSAID eye drops, specifically difluprednate and bromfenac, nepafenac, which are supposed to reach up to the retina even when delivered in form of eye drops. And then oral medications, antioxidant vitamins, and vitamin D3 is known to have beneficial effect if administered. So this is about the medical management in forms of medications, drugs, and eye drops. Then comes one of the very important innovation in retinopathy, that is intravitreal injections in form of anti-VEGF medications and steroids. They are known to control the macular edema, reduce or retard the proliferation, and also enhance perfusion of the retinal circulation. So this is one patient who had diabetic macular edema, and we can also see there's some amount of VMT, that is vitreomacular traction, and patient was injected with anti-VEGF injection, and after 4 weeks we can see there's improvement in the macular edema, and I can demonstrate this thickness map which shows a significant improvement at 4 weeks, and now the patient has much reduced macular edema, rather the contour has come down to the nearly normal levels, and we have still some VMT here, and there was a significant visual gain. So this is about intravitreal medications which help a lot in improving the vision, which was earlier very difficult task to achieve. And then we have laser, which will be the definitive management and will stabilize the disease for long terms. Pan-retinal photocoagulation is one technique which will improve upon the perfusion of the central retina by knocking out the peripheral, so not so important retina, and this will improve the blood circulation and also reduce the ischemia, and the byproducts of ischemia are reduced, and you have stoppage of the proliferation and bleed, and this can be a long-term solution for these patients. So pan-retinal photocoagulation should be considered for any person who is severe in PDR or PDR. And then we come to the surgical management of diabetic retinopathy, and this includes pars plana vitrectomy alone or along with ILM peel, ERM peel, and tamponade. And the indications would vary from hazy media due to bleed, vitreous hemorrhage, tractional retinal detachment, epiretinal membrane causing macular pathology in form of distortion of the retinal surface, or macular edema. And this is one patient who presented to us with dense hemorrhage, no view of retina at the time of presentation, and we operated him, and this is the result, and we can see that the media is cleared, there's silicone oil in the cavity, and there's still a proliferation, flat proliferation present on the retinal surface, which is not easy to remove without damaging the retina. So these tightly adhered membranes are usually left behind, and some laser is done around them so as not not to allow the traction to spread around the normal retina. And in these situations, the consent is very important, because the consent is something related to the outcome. The outcomes are not very good, in a sense that patient usually do not gain 6 by 6 vision. So outcomes has to be explained to the patient that this is best we can do, and that is why the consent is so very important, because patients' expectations should be realistic. So this is from this situation to this, where patient received ambulatory vision, and patient's vision at this time was with the improvement 6 by 36, which I think is good enough. And this is the other eye of the patient, where we can see that the dense proliferation has caused a traction retinal detachment involving the macular area, and this is seemingly impossible situation to handle, although I have promised the patient surgery. But I know that the consent has to be for the situation where we may not be able to improve anything. So that is why the consent process has to be realistic, and patient has to understand what he will get out of the procedure. Thank you for your listening.